Good morning. Dr. Page couldn't be here this morning, so I have the pleasure of introducing our grand round speaker, one of our own, Dr. Greg Gauthier, who's an associate professor in the Department of Medicine in the Division of Infectious Disease. He also has a joint appointment in the Department of Medical Microbiology and Immunology. Greg completed his undergraduate degree at Colby College, followed by medical school at The Ohio State University. He completed his residency, chief residency, infectious disease fellowship at UW-Madison. He then undertook graduate and postgraduate work in the laboratory of Bruce Klein. After that, we were fortunate enough to recruit him to our faculty in 2006, I think, and he was promoted to associate professor in 2014. Greg really is a treasure, not only for our division, but for the entire university. He's one of those rare, successful triple threats that are common, I think, across many of the people in our division, patterned after Dr. Mackey. He's an excellent clinician and has received numerous awards in that area, as well as for his research that we'll hear a little bit about today. Quite an interesting title, Beware of the Dirt, Developments in Blastomycosis. Thanks, Greg.
Thank you, Dr. Andes, for that wonderful introduction. And I'd like to thank Dr. Page as well as the Chief Residents for inviting me to speak today. Before I begin my talk, I would like to acknowledge the members of my lab, the mentorship and generosity of Dr. Bruce Klein, whose lab I trained in, as well as everyone current and former in his lab who I've had the privilege to interact with, collaborators at the UW, Côte d'Alpal, Broad Institute, my former Department of Medicine Mentoring Committee, the Department of Medicine Division of ID, as well as funding sources current and prior. The objectives for this lecture is to understand the geography and ecological niche of blastomyces, understand the knowledge that has been gleaned from investigating outbreaks, the clinical manifestation, how blastomyces causes infection, as well as the importance of dimorphism for pathogenesis, advantage and limitations of diagnostic tests, and finally antifungal agents that are active against blastomyces. And I would like this to be case-based, so we'll start off with a case. 25-year-old male presented to his primary care provider in October with progressive cough, shortness of breath, fatigue, fever. Chest x-ray demonstrated an infiltrate. He was prescribed azithromycin. He initially had some improvement. However, his respiratory symptoms worsened. He became hypoxic. He was admitted and started on broad-spectrum antibiotics. And while on antibiotics, his chest x-ray dramatically worsened, and he developed acute respiratory distress syndrome. He enjoyed spending his time outdoors, taking his dog for walks. Early in the summer, he went tubing on a river with some friends. His friends were also ill with respiratory symptoms and fever. Bronchoscopy with BAL shows the following organisms on smear: broad-based budding yeast, and you can see the broad-based bud here. How did he acquire his infection? Was it via respiratory aerosol exposure from his friends, from his dog, from the water, or from the soil along the riverbank? It was from the soil. Blastomyces, the etiologic agent of blastomycosis, is endemic to the Midwest, South Central, Southeastern United States, as well as several Canadian provinces. It has been reported in 18 countries in Africa, shown in orange. The incidence in the endemic area in North America is 0.2 to 1.94 cases per 100,000. And within the hyperendemic area, there are hyperendemic areas, including Vilas County in northern Wisconsin, Eagle River, which is in Vilas County, in the Kenora catchment area in Ontario by Lake Superior. Blastomycosis has been reportable to the DHS since 1984. There are 5 other states that require its reporting, as well as 2 Canadian provinces. And for patients who have symptomatic disease, over 60% require hospitalization. In 2013, Elizabeth Brown and colleagues did phylogenetic analysis of a large collection of blastomyces, isolates from North America and Africa, and they were from human, canine, and environmental sources. And they found that blastomyces should actually be divided up into 2 species. The one that we know and love, Blastomyces dermatitidis, and now a new species, Blastomyces gilchristei, and this is named after Dr. Gilchrist, who first described blastomycosis in the late 1890s, and he was actually the head of dermatology at the University of Maryland, a fellow Big Ten school. And Elizabeth Brown and colleagues compared the ratio of Gilchristei to Blastomyces dermatitidis in Ontario as well as Wisconsin, and what they found is that a large proportion of the Wisconsin isolates, as shown here, were Gilchristei, and a smaller proportion was Blastomyces dermatitidis. There was only 18 isolates from Wisconsin, and whether or not this ratio will hold true remains to be seen as more and more isolates are analyzed. Blastomycosis can occur sporadically, or it can occur in outbreaks. And Wisconsin has been the home of 9 of the 17 outbreaks of blastomycosis. The first was in the late 70s, in which 8 people got infected canoeing on the Namakaegan River. The second outbreak in 1984, 48 patients were infected at an abandoned beaver lodge. And this outbreak was significant because it really enhanced our understanding of the epidemiology and ecology of blastomyces, and was published in the New England Journal of Medicine. Dr. Bruce Klein, professor of pediatrics, was the lead author. And this was significant for 3 reasons. The first is that it allowed us to determine the ratio of symptomatic to asymptomatic blastomycosis. This was not known previously, especially because skin testing for blastomycosis is not available, unlike histo and coccidioides. And so about 54% were symptomatic, the remainder were asymptomatic. Risk factors for acquiring disease was standing on a beaver lodge, picking up objects by the log. The second area was that it allowed determination of the onset of infection, in other words, the incubation period, which was 21 to 106 days, so roughly about 3 weeks to 3 months. The third significant outcome is that blastomyces was isolated in the soil, and this was the first time blastomyces had ever been isolated in the soil associated with a human outbreak. And the soil samples that grew blastomyces from the beaver lodge had a high organic content, acidic pH, and had decomposing wood near the beaver dam. The following year, there were outbreaks around the Tamara River and the Crystal River, and this confirmed the incubation period, 23 to 78 days, again, roughly 3 weeks to about 3 months. And again, blastomyces was able to be isolated, further defining the ecological niche in Wisconsin. It's forested sandy soils of acidic pH, located nearby water, and containing decaying vegetation. In 2008, Dr. Kurt Reed, or former microbiology lab director, Jennifer Meese at Marshfield, John Archer of the state, and Dr. Peterson of Kansas did ecological niche modeling of blastomycosis. And they looked at a number of variables, including human and canine cases. And the areas in red represent favorable habitat in Wisconsin for blastomyces to grow, and you can see a large chunk of Wisconsin is red, especially the northern portion. And most of these areas are around or nearby waterways. And when we look at the human blastomycosis case incidence by county of residence from 2005 through 2014, which was supplied by the Division of Public Health, we can see that this map pretty much mirrors what we saw for the ecological niche modeling, is that blastomycosis has been reported in most of the counties in Wisconsin, and especially up north. From 2005 to 2014, there have been just over 1,200 cases. We do not have the data in yet for 2015. Since 2005, there's been increasing incidence of blastomycosis in Marathon County. And from September to June in 2009, 2010, there was an outbreak. 55 patients were infected, 70% were hospitalized. And what was unique about this outbreak is that 45% had Asian ethnicity, and this had never been reported before for a blastomyces outbreak. Moreover, the majority of those patients with Asian ethnicity were Hmong, and this shows the blastomyces cases per 100,000, and the dashed line shows those with Asian ethnicity, and it's much higher than those with non-Asian. Moreover, when they look back around 2005, 2006, there was another peak that wasn't expected, and this was associated with an outbreak in a neighboring county. And so the question is why would there be increased incidence of blastomycosis in the Hmong population? In other fungi, such as coccidioides, which is the etiologic agent coccidiomycosis, it is known that patients with Filipino ancestry have higher rates of dissemination. It is speculated for coccidioides there may be a genetic basis of susceptibility. So the question is blastomyces in the Hmong population, is there genetic susceptibility? And this research is being headed up by Dr. Caitlin Pepperell in the Division of ID, Dr. Bruce Klein, Department of Pediatrics, as well as several collaborators at the University of Wisconsin. And their hypothesis is that the Hmong are susceptible to infection due to genetic variants that alter the cytokine response, such as the cytokine IL-17 either being too high or too low. And they are doing whole genome sequencing for Hmong patients that are infected and looking to see if they can identify loci that are linked with susceptibility to infection. And then they will go on and do functional testing with regards to gene expression and immunity. So this work is ongoing and very exciting. Currently, there's an outbreak of blastomycosis on the Little Wolf River. This has received quite a bit of press, and the Little Wolf River is located here. It was associated with people tubing along the Wolf River. The DHS has put up health alert signs warning people of blastomycosis along the Little Wolf River. And there have been so far 90 reported cases, making this the largest outbreak reported to date. 51 confirmed, 39 probable, and unfortunately, there has been one death. So our patient had a dog, and we asked about the dog, and the dog was healthy. Why do we care about the dog? Well, canine blastomycosis can be a harbinger of human disease, and what it represents is a common source of exposure that the dog and the human were exposed at the same site. And in Wisconsin, it is estimated that canine blastomycosis is 10 times higher than it is for human blastomycosis, and it's likely because the dogs have their nose to the ground a little bit more frequently than we do. And the map of canine blastomycosis, which unfortunately is not reportable in Wisconsin, it's based on passive reporting, pretty much mirrors the map of what we saw for human disease. Clinical case number 2, 54-year-old female with a history of coronary disease and hyperlipidemia developed a progressive cough in late autumn. PA and lateral chest x-ray shown here was normal. She did not have it. She was prescribed levofloxacin for 5 days, no fevers, chills, or night sweats, no weight loss, no hemoptysis. In January, she developed chest pain and thoracic pain. A CT was performed, which demonstrated a new nodule in the left lung apex. She owns a business, it's by a river, and she walks to it each day. What is her clinical presentation most consistent with? Non-small cell lung cancer, pulmonary cryptococoma, pulmonary histoplasmoma, or pulmonary blasto? Well, since this is a blasto talk, it's pulmonary blastomycosis. And the key point for this is that blastomycosis can be a great mimicker. When she had her CT scan, the main concern was that this represented malignancy. And that's what she was told this likely was until the biopsy happened and it showed blasto. So blastomyces grows in a mold form and produces spores in the environment. Following the disruption of soil, the spores and mycelial fragments are aerosolized and inhaled into the warm lungs of a human host and convert into pathogenic yeast to cause pneumonia. About 25 to 40% develop disseminated disease, with the skin and the bone being the most common sites of dissemination. Fortunately, the CNS is a rare site of dissemination unless you have AIDS. So for pulmonary blastomycosis, roughly 60 to 77% of patients will have isolated pulmonary disease. In terms of the spectrum of pulmonary illness, about half will have a mild flu-like illness or subacute pneumonia, and thus don't come to clinical attention. And this, again, was gleaned from outbreak studies. The other half have symptomatic pneumonia. Cavitary disease occurs in less than 15%, and acute respiratory distress syndrome generally occurs in less than 10%. In terms of symptoms, symptomatic pneumonia is very similar to community-acquired pneumonia, and chronic pneumonia is very similar to tuberculosis, in which you have fevers, chills, night sweats, and weight loss. There are no pathognomonic findings for blastomycosis by radiography. Consolidation is generally the most common pattern, but you can have masses such as our patient that can be mistaken for malignancy. You can have cavitary lesions that can be mistaken for tuberculosis. You can have nodules. You can have a miliary pattern, which can also be confused with tuberculosis. And finally, you can have mixed patterns. Dr. Meyer, Dr. McManus, and Dr. Mackey here at the UW published in 1993 in the New England Journal of Medicine a seminal paper on blastomycosis causing acute respiratory distress syndrome. And this is an important condition or clinical manifestation to recognize. In their patient population, fever, cough, dyspnea was common. There was a high rate of extrapulmonary dissemination, 65%. There was a high yield for fungal smear, 95%, and sputum culture, 90%. And what was really startling was the mortality for the UW patients. The mortality was 50%. And when they went back and reviewed the literature and added that to what was the UW, the mortality was 68%. And this high rate of mortality was also seen by Dr. Vasquez, who looked at blastomycosis in northeast Tennessee. They had 9 patients who had ARDS. About 33% had disseminated disease, but their mortality was 89%. And what contributed to this high mortality was that 3 of the 9 patients, or I should say 3 of the patients were not recognized to have blastomycosis until after they died. So thinking about blastomycosis in someone with ARDS is important and has the potential to reduce the mortality because you can institute therapy earlier. For cutaneous blastomycosis, it has a heterogeneous presentation. Verrucous lesions, exophytic lesions, nodules, ulcers, and plaques. Osteomyelitis in the bone is the second most common site of dissemination, occurring in 6 to 21% of patients. Clinical features include bone pain with soft tissue swelling, abscess, and fistula formation. Concomitant pulmonary involvement is common. Majority will have a single bone lesion, but you can have patients with multiple bone lesions. The spine, long bones, and ribs are most commonly involved. Granulomatous inflammation is seen here, and you have to do special staining, such as a Gamorrean methamine silver, to visualize blasto, and it can be misdiagnosed as bacterial osteomyelitis and a bone tumor. In terms of genitourinary disease, in the older literature, up to 30% of patients with disseminated disease had GU involvement. However, in the modern literature, it's much lower, approximately 2 to 7%. Genitourinary disease most often affects men, resulting in prostatitis or prostatic abscess, with symptoms of dysuria, nocturia, retention, suprapubic discomfort. Pulmonary or skin involvement is common. Histopathology shows granulomatous inflammation, and it can be misdiagnosed as bacterial prostatitis if special stainings aren't done. Laryngoblastomycosis is uncommon, but I would like to spend a few moments on that because people have been misdiagnosed with laryngoblastomycosis as malignancy and have undergone laryngectomy or radiation therapy. And it can present similar to laryngeal cancer with progressive hoarseness, sore throat, dysphagia. Pulmonary involvement is only seen at about half. You can see polypoid masses and decreased vocal cord mobility on laryngoscopy. And in terms of the histopathology, you tend to see pseudoepitheliosis hyperplasia, and you can have atypia, which can fool people to think this could be malignancy. At times, you can also see microabscesses, and the key is that there's an absence of true dysplasia or basement membrane invasion. Again, you need special staining to identify the yeast. And for CNS blastomycosis, this occurs in less than 5 to 10% of patients without AIDS. It occurs up to 40% of patients who do have AIDS. And in terms of the spectrum of disease, it's roughly about a third with meningitis or meningoencephalitis, a third with abscess, and a third have a mixed picture. And as expected, you would have headache, confusion, seizures, focal neurologic deficits. Extra CNS disease occurs in the vast majority of patients, 77 to 98%. So the majority of patients with CNS blastomycosis will have other clinical manifestations, whether it's pulmonary or skin involvement. CSF profile can be neutrophilic or lymphocytic. The protein can be normal or elevated. Glucose can be normal or low. And the CSF culture generally has low yield and is positive in less than 50%. Clinical case number 3. 45-year-old male without known immunocompromised developed 28 widespread cutaneous nodules. Over a period of several weeks, all but 3 lesions on his face and buttocks spontaneously healed. The remaining lesions became progressively larger. He lives in rural Wisconsin, enjoys spending time outdoors, and recent outdoor activities have included hiking and trimming trees. And these are some of the nodules in the early stages on his cheeks. And when he presented to the infectious disease clinic, there was extensive involvement of the face, including encroaching on the eyelid. Biopsy was performed, which showed granulomatous inflammation with yeast. Close-up shows broad-based budding yeast consistent with blastomycosis. Culture grew blastomycosis. He was admitted to the hospital, started on amphotericin, and transitioned down to oral itraconazole. And you can see that over time, the healing started centrally and progressed outward, but left him with extensive scarring. And it's very typical for blastomycosis skin lesions to leave a scar. And for him, because it encroached on the eye, it resulted in an ectropion. And once he finished therapy and we were convinced there was no evidence of relapse, Dr. Lucarelli and colleagues of oculoplastics here repaired the ectropion and had a wonderful outcome. So what's going on? These 3 patients have all been healthy. They have not had known immunocompromise. And so what features allow blastomyces dermatitis to cause infection in healthy hosts? Is it thermotolerance at 37, the ability to convert to yeast morphology, active evasion of the host immune system, or all the above? And it's actually all the above. For any fungi to cause disease in humans, it must be able to survive at 37 degrees Celsius. And for this portion of the talk, I would like to focus on some of the basic science underlying the pathogenesis of blastomycosis. And I would like to point out that there are very few labs in the country that work on dimorphic fungal infections, and even fewer that work on blastomyces. And the bulk of this work has been done on pathogenesis here at the UW. So Blastomyces dermatitis and Gocrestii are a part of a group of pathogens known as thermally dimorphic fungi, which convert between mold and yeast forms. This includes Histoplasma, Coccidioides immitis and Posidacea, Talaromyces marneffii, which used to be known as Penicillium marneffii, and Paracoccidioides brasiliensis and Lutzii. In 2013, a new dimorphic fungal pathogen for humans was described in South Africa in patients with AIDS. And this is the novel Amansia-like species that converts between mycelia to yeast forms here that you can see in an immune cell. And since its initial report in South Africa, it has been described in other countries: China, the Czech Republic, Germany, the United States, and Canada. And Amansia has been misdiagnosed as blastomycosis as well as histoplasmosis. And it typically involves pulmonary as well as cutaneous findings. And of 55 well-described patients, 53 were co-infected with HIV or had AIDS. And 1 of 55 patients had a renal transplant. In addition to thermally dimorphic fungi, there are non-thermally dimorphic fungi which can infect plants, such as the Ophiostoma species, which causes Dutch elm disease, Eustoligomatus, which causes corn smut, and this is a delicacy in Mexican cooking. And then there are also dimorphic insect pathogens. The Ophiocordyceps species is well known as the zombie ant fungus, which basically invades the ant, infects its brain, and controls its behavior. So back to the thermal dimorphs. So temperature is the predominant stimulus that drives the transition between the mycelial form and the yeast form. In 2006, Julie Nemechek, a graduate student in Dr. Bruce Klein's lab, discovered the first gene that regulates the transition from the mold to the yeast phase. This gene is known as DARK1. And when DARK1 is knocked out, the organism remains locked in the mycelial phase. So blasto remains locked and histo remains locked. And when the organism remains locked in this mycelial stage, it is avirulent in a murine model of infection for both blastomyces and for histoplasma. Moreover, the mouse is able to clear the infection. And this provided the first genetic proof that the transition from the mycelial phase to the yeast phase is absolutely essential for virulence. Alana Sterkel, our medical microbiology lab fellow, did some elegant work describing the facultative intracellular lifestyle of blastomyces, which was published last year. Prior to this, blasto was thought to be exclusively an extracellular pathogen. And so blastomyces spores in red can be ingested by alveolar macrophages in green, and you can see them here. Once in the macrophage, the spores can germinate into replicating yeast within alveolar macrophages, and this germination is actually accelerated when it's in the macrophage. So in other words, it germinates faster from a spore to a yeast inside the macrophage than outside the macrophage. And blastomyces can replicate as budding yeast within the macrophage, and thus the infected alveolar macrophages can help propagate infection. In the yeast phase, blastomyces produces BAD1, which stands for Blastomyces adhesin 1, also known as WI1, and it was discovered here at the University of Wisconsin when Dr. Klein was investigating novel ways to diagnose blastomyces serologically. And BAD1 is found in bound insoluble forms. It facilitates adhesion to lung tissue through binding of heparin sulfate. It also is able to inhibit TNF-alpha production. The bound form is by binding CR3 and CD14 receptors, and this is done by TGF-beta-dependent inhibition of TNF-alpha production. The soluble form can bind CR3 receptors, be uptaken by the macrophages, and inhibit TNF-alpha production, and this is a TGF-beta-independent mechanism of inhibition. More recently, BAD1 has been found to impair the activation of CD4 T cells and decrease cytokine production such as IL-17 and interferon gamma. When deleted from blastomyces, when BAD1 is deleted from blastomyces, the strains are rendered completely avirulent in a murine model of pulmonary infection. As you can see, blastomyces, or mice infected with BAD1, live for at least 30 days, and if you extend this out, they can live for several months. In contrast, those infected with the wild-type dye, the BAD1 null mutant does not cause significant inflammation and is cleared from the lung. To identify additional virulence factors, a collaborative effort was done to do in vivo transcriptional profiling of blastomyces during active murine infection. And this was a collaborative effort between the Broad Institute, Dr. Klein's lab, and my lab. And one of the first things we needed to do was to isolate blastomyces yeast from lung tissue, and we had to develop a novel technique doing that, and we were able to take advantage of the differential density of blastomyces yeast compared to mammalian tissue. And when we did the in vivo transcriptional profiling, we found a group of genes that were highly upregulated only in the mouse. And some of these genes we are currently looking at, including zinc acquisition proteins. There's also upregulation of genes involved in cysteine metabolism, as well as lipid biosynthesis. And so this is ongoing work. So we've learned a lot about why blastomyces needs to go from the mycelial phase to the yeast phase. It's essential for virulence. What about the other direction, the conversion from yeast to mycelia? This is important for three reasons. The first is it allows for environmental survival. The second is genetic diversity through mating. So blasto has sex in the soil, and this is a mating structure for Blastomyces. And finally, there's the transmission of Blastomyces spores and mycelial fragments to hosts. This dimorphic lifestyle is essential to the biology of the dimorphic fungi. And John Taylor's group out in California found that one of the Coccidioides strains in Texas had the same migratory pattern to Mexico, Central, and South America as human migration 10,000 years ago. And so what they speculate happened was that humans and the animals that migrated with them would become infected, they would die, the organism would return to the soil, and then it would be picked up by new hosts and transmitted southward. My lab has looked at this transition, and we identified SRAB, which is the first transcription factor described that regulates the transition from yeast to mycelia. And on this time course here, when you knock out SRAB, there's a defect in the transition to mycelia compared to the wild type. Moreover, there's defects in iron regulation, and under iron replete media, the no mutant cannot shut off iron uptake mechanisms and thus is colored yellow because it continues to uptake iron. And finally, there's a defect in lipid biosynthesis. Specifically, the null mutant has decreased triacylglycerol and ergosterol biosynthesis. And this correlates to around these time points where we first see the morphologic defect. And this prompted us to look at lipid droplets. And lipid droplets are organelles that store triacylglycerol and ergosterol. And using a special stain called Bodipi, we found that there was almost no lipid droplets in the developing filaments. And when we added back fatty acids, specifically saturated fatty acids, we found that lipid droplets were restored, similar to wild type, at the 24-hour time point, and there was acceleration of the morphologic shift. And these lipid droplets at 48 hours, so about, were basically gone. And this indicates that lipids and lipid metabolism is active during the phase transition from yeast to mycelia, and that lipid droplets are actively consumed. Interestingly, a homolog of SRAB and Cryptococcus neoformans, SIR1, is absolutely essential for growth at 37 degrees Celsius, and the null mutants are avirulent. So in the dimorphic fungi, Blastomyces, as well as histoplasma, SRAB is important in adapting to lower temperatures, whereas the same gene in Cryptococcus is critical for adapting to higher temperatures. Clinical case number 4, a 68-year-old male immunosuppressed by renal transplantation who's currently being treated for CMV encephalitis developed fevers, respiratory failure requiring mechanical ventilation, and new onset ascites. Broad-spectrum antibiotics were started for treatment of pneumonia and peritonitis. Paracentesis demonstrated 115 nucleated cells, 61% neutrophils. Calcifor staining of acidic and BAL fluid showed broad-based budding yeast consistent with Blastomyces. These are his nodules. This is the acidic fluid. And so which of the following are true for solid organ transplants with blastomycosis? High incidence of respiratory failure, high rate of dissemination to the CNS, opportunistic co-infections are common, and lifelong therapy is required for all patients. The answer is A and C. And I'd like to talk about our experience of blastomycosis in the solid organ transplants here at the University of Wisconsin. And we did a retrospective review from 1986 to 2004. We found 11 patients. Cumulative incidence was about 0.14%. Median onset was 26 months, and roughly half the patients developed infection within their first year of transplant, and the other half after the first year of transplant. 82% of patients had pneumonia. 78% with pneumonia had respiratory failure, and 67% had acute respiratory distress syndrome. Disseminated disease occurred in 36%, with the most common site being the skin. We did not see central nervous system disease, and review of the literature revealed that CNS blastomycosis in the transplant population, unlike patients with AIDS, is rare. Mortality was 36% overall. However, it increased to 67% in patients who had ARDS. And for the patients who survived, who received a full course of therapy, relapse after stopping therapy did not occur. What about other centers? Grimm and colleagues did a multi-center retrospective study at Rush, University of Illinois, Chicago, and Iowa, and they had 8 patients, and they found similar results. Pneumonia occurred in all patients. Disseminated disease was a little bit higher, 50%. Mortality was similar, 38%. And they only had 1 patient relapse after stopping therapy, and that was a patient who had been treated for only 6 months, and therapeutic drug monitoring was not done while they were on itraconazole, so it was unknown if they had therapeutic levels. In terms of the Transnet database, which Dave Andes in the UW is a member, between 2001 and 2006, there were 9 patients. 77% had pulmonary disease, 33% disseminated disease. What about blastomycosis and TNF-alpha inhibitors? In September 2008, the FDA put a warning indicating that patients who are receiving TNF-alpha inhibitors are potentially at higher risk for endemic fungal infections, and that includes histo, blasto, and coccidioides. And at that time of the warning, the FDA had 7 cases had been reported for blastomycosis. The vast majority for that warning were histoplasmosis. In terms of more recent data, Salt and colleagues in 2015 found 6 cases of blastomycosis out of just over 30,000 patients receiving TNF-alpha inhibitors. So overall, blastomycosis is an uncommon opportunistic infection in patients on TNF-alpha inhibitors. Clinical case number 5, 54-year-old female with diabetes underwent kidney pancreas transplant, admitted to UW for fevers, drenching night sweats, mild cough without dyspnea. Symptoms began in the late spring, early summer, and slowly progressed. This prompted evaluation by her physician. Chest x-ray demonstrated pneumonia. Antibiotics were started, did not improve her symptoms. She had a 10-pound weight loss, nausea, vomiting, and a draining neck lesion. She has significant risk factors for fungal infection. She lives on a farm in northern Illinois. There's a pond in the backyard. The house was renovated. Outside her home, she lay mulch. Her husband did landscaping, and she has visited her sister who lives in northern Wisconsin. The dog is healthy. Which of the following tests are most useful for diagnosing blastomycosis? Clinical suspicion for fungal infection, fungal smear and culture, beta-1,3-glucan test, serum or urine blastomyces antigen, or complement fixation antibody. And the answers are A, B, and D. And in my opinion, the most important diagnostic test for blastomycosis is clinical suspicion, thinking about the organism. So when do we want to think about fungal pneumonia? One is when pneumonia fails to respond to antibiotics. When there's the presence of pneumonia plus skin lesions. So in your patients that are admitted or you're seeing in the outpatient clinic, doing a good skin exam can be very helpful. And if there are skin lesions, that increases the risk that they have a fungal infection substantially. Anyone with acute respiratory distress syndrome, if there's been blastomycosis in a family pet, such as a dog or a cat, travel or live in the endemic area, if there's been significant soil disruption, such as home remodeling, road or building construction, and Indianapolis, there's actually been an increase in blastomycosis associated with highway construction. Outdoor activities such as hunting, fishing, camping, boating, and now tubing along a river. Logging or tree cutting, use of a community compost pile, which was described as an outbreak in about 10 years ago, and finally use of a wood-burning stove. Blastomyces has been isolated underneath wood piles. So in terms of diagnosis, these are divided into culture and non-culture based diagnosis, and overall the yield for sputum smear can be about up to 80%. For sputum culture, yield is generally about 75%, but can be higher. You must request a specific fungal culture. And in terms of bronchoscopy with BAL, it's 92%, and about half will have mucosal abnormalities. In terms of non-culture-based diagnostics, the antigen EIA has really revolutionized the way we diagnose blastomyces, and this detects a cell wall galactomannan, and you can obtain specimens from the urine, serum, BAL fluid, and CSF. The sensitivity for the urine is around 81 to 93% with a specificity of 77 to 79%. And you can actually use the antigen EIA to follow patients' response to therapy. And there was just an article published on this in November. In terms of serology, complement fixation or immunodiffusion have very poor sensitivity and really don't add anything to your diagnostic testing. In terms of beta-1,3 glucan, Blastomyces yeast has about 5% beta-1,3 glucan, so thus the beta-1,3 glucan is poor sensitivity because blasto yeast just don't have a lot of beta-glucan. And in terms of histopathology, you look for pyogranulomatous inflammation along with yeast. So in terms of this antigen EIA assay, it does have significant cross-reactivity with histoplasma capsulatum, about 96%. It also cross-reacts with Paracoccidosis brasiliensis and Talaromyces or Penicillium marneffii. However, these two organisms are not really a big deal unless the patient has traveled to South America for Paracoccidioides, or they're immunocompromised and either travel to or live in Southeast Asia. So how can we potentially differentiate blasto from histo using non-culture diagnostic tests? There has been developed a new serologic test against BAD1, which we know is an essential virulence factor expressed only in the yeast phase. It's only found in Blastomyces, and it's critical for immune evasion. The sensitivity is 87%, specificity about 94 to 99%. And if you combine the BAD1 antibody with the antigen detection, your sensitivity goes up to about 97%. Back to the case. The fungal smear of the sputum shows broad-based budding yeast by chalcophore stain shown here. Fungal cultures in progress. Urine Blastomyces antigen is positive. What antifungal therapy do you recommend for a renal transplant patient? Lipid ampho, itraconazole, high-dose fluke, or echinocandin? It's lipid amphotericin. In 2008, the Infectious Disease Society of America put forth guidelines for the management of blastomycosis. And for patients with mild to moderate pulmonary disease or mild to moderate disseminated disease, you can start off with itraconazole. However, if you have more severe pulmonary disease or severe disseminated disease, you start off with a lipid amphotericin product for the first 1 to 2 weeks, and then step down to itraconazole for approximately 6 or 12 months of therapy. For patients who are immunosuppressed, it is recommended to start off with a lipid amphotericin product and can step down to itraconazole for 12 months. For CNS disease, it's a lipid ampho product for 4 to 6 weeks, followed by step down with either itra, vori, or fluconazole for 12 months. And for pregnant women, it's only lipid amphotericin. Azoles are contraindicated. So in terms of amphotericin, I'd just like to touch base on a few practical aspects. As we know, it can cause renal dysfunction. The lipid formulations have left nephrotoxicity. You want to avoid other nephrotoxic agents. And it's important to do salt loading, which is basically pre and post hydration with normal saline. And several studies have shown that this reduces the rate of renal dysfunction. Hypokalemia and hypomagnesemia are common, and I usually start potassium and magnesium supplementation at the same time. Infusion reactions can occur, and so most providers will usually pre-medicate with acetaminophen and diphenhydramine. In terms of itraconazole, there are some practical aspects in terms of how it's given in terms of the capsule versus the liquid formulation. For the capsule, it starts with C, and a C with a line over it is the abbreviation for with. So you take your capsule with food and with acid. The solution is the exact opposite. It has an S and an S with a line over it is without, so you take it without regard to food or without regard to acid. You should do therapeutic drug monitoring while on itraconazole. First drug level obtained about 14 days. The level can be drawn any time, and the goal level is greater than 1. And you want to be adding both your itraconazole and your hydroxyitraconazole levels together. In terms of other azoles, voriconazole, posaconazole, and the newest drug, isovuconazole, all have good activity against the dimorphic fungi. And again, it's important to administer these properly. Voriconazole requires an empty stomach. For posaconazole, the solution requires a high-fat meal and acid. The capsule formulation, which is much easier to take, does not have any food requirements. Similarly, isovuconazole does not have any food requirements either. Therapeutic drug monitoring should be done for vori and posi, ideally a trough within the first 7 to 10 days. Goal level greater than 1, or 0.7 to 1 for POSI. As of now, there's no therapeutic drug monitoring for isovuconazole. Isovuconazole does have a unique side effect in that it can shorten the QT interval, where these others can prolong the QT. There's lots and lots of drug-drug interactions with azoles, so before starting azoles, it's important to check for these interactions. One of the most common is with statin drugs, such as a stimvastatin and a torvastatin, and it is recommended that if you have to continue with statin, you switch over to pravastatin, which is not affected by azoles. And finally, before starting azoles, it's very important for adolescents and women of childbearing age to be doing a urine pregnancy test, because high-dose azoles can result in congenital malformations that appear similar to the Antley-Bixler syndrome, in which there's craniofacial abnormalities, skeletal malformations, and cardiac malformations. Echinocandins are not effective, and that's because Blastomyces yeast has less than 5% beta-1,3-glucan, and the target for echinocandins is beta-1,3-glucans. So don't use echinocandins to treat blasto. And finally, I'd like to wrap up with vaccine development. The BAD1 knockout strain represents the first genetically engineered recombinant fungal vaccine, and it produces sterilizing immunity in mice against lethal dose of Blastomyces. And there is ongoing research here at the University of Wisconsin to understand the requirements for vaccine-induced immunity. More recently, calnexin, which is typically an ER protein, has been found on the surface of the fungal cell wall, and it can induce the expansion of calnexin CD4 cells. And when you administer calnexin that is conjugated to glucans, it expands these T cells and provides effective immunity. So this is ongoing research at the UW in an effort to develop fungal vaccines. And what's really neat about these two vaccines is they provide protection against a wide range of fungi. So take-home points. There's two species of Blastomyces, Dermatitidis gocrestii. Its ecological niche is sandy soil, acidic pH, nearby water, decaying vegetation. Pneumonia is the most common clinical manifestation, and think of ARDS. Disseminated disease is common. Yeast mycelial dimorphism is essential for pathogenesis. BAD1 is an essential virulence factor. For diagnosis, the most important diagnostic test is to actually consider the diagnosis of blastomycosis. You can get smear, culture, antigen test. The BAD1 antibody test is up and coming. In terms of treatments, it's either amphotericin or azoles, and always get a pregnancy test in a woman of childbearing age prior to initiating azole therapy. And again, I would like to acknowledge those, again, who have helped me out throughout the years.
Thanks, Greg. As always, very excellent presentation. We certainly have time for a few questions.
I had a question about the epidemiology. In one of your first slides, you showed Northern Africa and Egypt.
Yes.
It's an extremely dry, hot climate where, as I understand it, fungi just don't grow.
So in terms of that, yes. So in Africa, it's been rarely reported. There's been about 100 reported cases of blastomycosis that have been confirmed. Unfortunately, we don't have a lot of information in terms of kind of, where these infections have taken place. Like, for example, were they along the banks of the Nile or not? The other is that the African strain of Blastomyces is different than the North American strain of Blastomyces. So there may be a little bit different behavior. And we don't have enough information in Africa in terms of enough cases to really be able to understand its ecological niche in Africa. So it potentially could have a different ecological niche. We just don't know. So the question is in people who have been previously infected with blastomycosis, is there an incidence of relapse or acquisition of new infection? And in terms of relapse, if people have been properly treated with an effective azole, the risk for relapse is quite low. In terms of reinfection, once people have been already infected, they do develop immunity against blastomyces that lasts for at least 2 years. We do not know the exact duration, but it's at least 2 years. So once you've been infected, the thought is that you're at lower risk of becoming infected again.
My question has to do with the interesting finding that this may have some, the Hmong population may have some predisposition towards blasto. I just wonder, is that controlled for, tendency for camping or some social activities that might, predispose the population to being around blasto in this way?
So the question is for the Hmong population, are there certain risk factors or activities such as farming, camping, and other outdoor exposures that increase the risk for developing blastomycosis? And in this study, that was looked at, and there was no higher risk for environmental acquisition for blastomyces compared to the non-Hmong population. They looked at specific things such as like gardening, camping, and other outdoor activities, and there was no higher incidence than the non-Hmong population.
Hey, Greg, that was great. About the 2 different species that have recently been described for blastomyces, dermatitis and Gregory, can you say a word about how the 2 species have been distinguished and whether there are any clinical implications as far as the Gregory having a different form of disease or a different kind of epidemiology?
So the question is, in terms of the 2 species that have been described, does Blastomyces goldcrestii have any unique clinical or epidemiologic characteristics? So in terms of that, the knowledge we're still learning. There is some suspicion or some thought that goldcrestii could potentially be a little bit more virulent, but a lot more work needs to be done with regards to many more isolates to truly understand that. And in terms of outbreaks, my understanding is or a number of previous outbreaks have been more associated with dermatitis rather than goldcrestii. However, with this current ongoing outbreak associated with the Little Wolf River, we'll have to see. So I think it's very much a work in progress to really understand if there are any clinical differences or epidemiologic differences, and we'll just have to wait and see, especially since this was just described only a few years ago.
Is there enough information to comment on how IL-17 or other cytokines is involved in?
So is there information with regards to how IL-17 and other cytokines work for the host? And so in terms of IL-17 and other cytokines, what they do is they help activate macrophages and other immune systems to have a fungicidal activity and help clear the infection.
Yeah, I was just wondering if there's any role for primary prevention, respirators, things like that for people in endemic areas, or who you know are constant or frequent.
In terms of primary prevention, the question is there a role for primary prevention, such as masks and others, mechanisms to prevent disease? Currently, there are no formal guidelines for primary prevention. However, when we do have transplant patients, we do try to educate them about, potential risks, such as, avoiding doing a lot of digging in the soil. If there's a lot of home construction, they probably should leave their home for a while, or if there's other sorts of activities that can dig up a lot of dirt or create a lot of dust, they should probably avoid that area or wear a mask. But again, that's not a formally kind of codified recommendation. Other pathogens that can be acquired from the dirt include, histoplasma, aspergillus, scedosporium, etc. So it's kind of a general fungal recommendation rather than blastomyces specific.
Well, if there are no more, oh, you have another question?
Well, so it seems like there must be a huge number of individuals who are exposed and undertake these activities and don't get the disease.
Yes.
So clearly the question is what's known about the difference. You cited ethnic differences, but what's known, say, within the Caucasian population, for example, about what makes some people get it and other people not?
So the question is in the, do we understand mechanisms of why some patients who inhale blastomyces develop clinical disease where others have asymptomatic infection? And that is something we don't quite understand yet, and there's quite a bit of variables for that. Some can be the size of the inoculum, and it's thought that the higher inoculum you get of blastomyces spores, the more likely you're going to get a symptomatic infection. Again, that's more speculation, but we really don't know the mechanisms of why some people will clear their infection and be asymptomatic, whereas others will go on to develop disease.
So with the anti-IL-17s becoming more common, would you expect to see increased rates of blasto? And have you heard of any yet?
I have, with the increased use of IL-17 inhibitors, would there be an expected increase in blastomycosis, and have I heard of any infections associated with IL-17 inhibitors? In terms of the increased risk while IL-17 inhibitors, I have not heard of anything. My suspicion is it might be more like what we saw with the TNF-alpha inhibitors, that it's uncommon, but we'll have to wait and see. I have not yet seen or heard of any cases of blastomycosis with patients on IL-17 inhibitors.
Well, great. Again, Greg, thank you so much.